We have a lot of new faces today.
Respected Professor, after a brief gap, I welcome you all to our RISA online academic activities today. This new session with new young faces who have joined our Anesthesia fraternity recently is a new batch. So I welcome you all once again on behalf of RISA online DNB academic activities with the blessings of our Professor Nagaswamy sir. I request Nagaswamy sir to proceed. Thank you, sir.
Yeah. We will just have a brief introduction of all the new PGs who have joined. We welcome you to 3 years of learning and improving your knowledge and then being useful to the society with very important and very tricky specialty, I would say, where you have to use. Even though artificial intelligence is going to take over in a few years, still our intelligence is very, very important. We cannot depend on artificial intelligence all the time. And I don't know how many of you saw the question paper, the fourth paper. The first question was artificial intelligence and anesthesia. So that is going to come up in a big way. But for that, basically, we should have our own normal intelligence sharpened well so that we can use our skills to the maximum benefit of our patients. Okay? So I find the name Nalliyal. Can you switch on your mic and introduce yourself, Dr. Nalliyal?
Good evening, sir.
Good evening. Where are you from?
I'm from Chengalpattu, sir.
You are from?
Did my UG in Karpagavinagar, sir.
Karpagavinagar, Pondicherry.
Madurai.
Madurai. Okay. Right. And your name is very unusual. Which part of Tamil Nadu you are coming from?
Coming from Chennai. Chengalpattu, sir. Chengalpattu, sir. Chengalpattu.
You belong to Chengalpattu?
Yes, sir.
Okay, right. Then there is another, who are all the other newcomers? Is there, Suta is old. Durai Yogeshwaran, where are you from? Can you switch on your mic and answer the questions? Durai Raj Yogeshwaran, I see a name like that.
Sir, I am from Virudhunagar, sir.
Virudhunagar. And you have joined in NIOT or Railways?
Railway, sir. I'm senior DMS.
Railway. Okay, very good. What about Kirti Reddy Banala? I think they are all from other institutions. So who are the other new primary PGs from NIOT?
Sir, I'm Kyle sir from Miyot Hospital, sir. Primary DNB PG.
Primary. Where did you do your UG?
Sir, PSG Medical College, Coimbatore, sir.
Coimbatore. Excellent. Very good.
Yes,
Very nice institution. Excellent. Then who are all the other newcomers? Anybody else who want to introduce yourself? Just switch on your video and audio and just introduce and then you can shut off. Nobody else. Okay. Right.
Hello, sir.
Dr.
I'm Dr. Anjani, sir.
From
Stanley Medical College.
Oh, excellent. Which year did you pass out?
I'm from Chennai, sir.
Chennai, and which year did you pass out? When did you clear your UG? Last year or year before? When did you complete your PG? Ranjani, are you able to hear me? How much am I audible?
Yes, sir.
Yes, you are audible, sir.
But Ranjani is not able to hear me, I think. She is not able to answer my question when she completed her. Okay.
Hello, sir.
So,
good evening, sir.
Good evening.
I'm Bindu. Joined as a new PG here, sir.
In NIOT. Have you joined in NIOT or Railways?
Miyot, sir.
NIOT. Okay. Right. So you have very good seniors to guide you and help you, all very studious students. So follow their footsteps and do well in your exams and try to clear with flying colors. So with this wishes to you, we will continue with our class. We have been discussing about the respiratory physiology relevant to anesthesia in the last two classes. This is the third class. We are going to continue with the same topic and finish it, try to finish it because already taken 3 sessions to complete whatever is relevant to anesthesia and respiratory system. So I will share my screen and it will be a didactic, not a didactic lecture, but an interactive session with question and answers. Even if the primary PGs, you know the answer, you can be bold enough to share your answers with us and try to see or assess your own knowledge, how much you know about this with regard to respiratory system. So I'll share my screen. Are you able to see the screen?
Yes, sir.
Yes, sir. Yes, sir.
So
Please, sir.
we'll start with the anatomy of human diaphragm today. This has been a question which has been repeatedly asked in the theory exam. And also from practical point of view, a lot of applied anatomy is to be known for this topic. So describe the human diaphragm anatomy. Can anyone start with the answer? India, or the one to contribute to the discussion all the time? Or Risha? What is the importance of diaphragm? What does it do actually?
Sir, it has two types of fibers, sir. So it can it can act as in both active and passive respiratory muscles, sir.
Okay. What is its primary function?
It is the principal muscle for respiration.
Muscle of respiration. Okay, it is the main muscle of respiration. And what does it separate?
Between the
Diaphragm.
thoracic cavity and the abdominal.
It separates the thoracic cavity and abdominal.
Very good. It separates the thoracic cavity from the abdominal cavity. That is another important function. Otherwise, we will be having everything in one compartment, isn't it? So this is a very important thing. So the diaphragm in the thorax is called the thoracic diaphragm and serves as an important anatomical landmark that separates the thorax from the abdomen. That is the first thing. And it functions during breathing. It contracts to enlarge the thoracic cavity. So when it contracts, what happens to the intrathoracic pressure? Or interpleural pressure?
Negative pressure is created.
It becomes negative. Why should it become negative? What are the things that are happening?
Down, sir. It pushes the abdominal content down. It goes down so that the volume, the thoracic cavity size increases and the pressure decreases, sir.
Okay, so but why should the pressure decrease? What is the advantage of this
So that
negative
the
pressure?
air from the
So
atmosphere.
that
Lungs to draw in
when the pressure becomes
In the lung,
less than
when
that,
air is sucked in or drawn in, okay, what else happens in the cardiovascular system?
the venous
return increases.
blood from the lower limb
Venous
usually
blood
comes.
also is sucked into the right atrium. Both the things happen. So it's a fibromuscular sheath that has a convex upper surface that forms the floor of thoracic cavity, and it has a concave under surface which forms the roof of the. It is like an apartment complex where somebody's roof is somebody else's floor, isn't it? Something like that.
Yes.
So fibromuscular sheath that has a convex upper surface. So the floor of the thoracic cavity is convex, whereas the roof of the abdominal cavity is concave. So it is in a dome-like fashion. That is the reason why it is happening. So what are the structures which pass through the diaphragm?
Sir, IVC, aorta, and esophagus.
IVC, aorta,
Thoracic duct.
Esophagus.
thoracic duct, esophagus. Esophagus is the three important structures. Major structures are IVC, esophagus, and aorta. Okay, these are the three structures. We will come to the level at which they enter at the different questions.
T68, T12.
So, esophagus, phrenic, vagus, descending aorta, inferior vena cava, all these things pass through between the thoracic and abdominal cavities. What is the origin of diaphragm? Where does it take origin from?
T7 to
T7?
T12.
Has it got only one origin like other muscles of the limbs, or does it got multiple
It
origins?
is central and peripheral attachments.
It has got multiple origins. So how can you classify this multiple origins? Which are all the neighboring bony structures from which they take origin?
Sternum, ribs, and the vertebrae.
Excellent. So origin of the diaphragm can be classified into sternal, which is two fleshy slits from the back of the xiphoid process of your sternum. Okay. So that is called the sternal origin of diaphragm. Then there is a ribs arising from the ribs. They are called costal origin. How many ribs contribute to the origin of diaphragm, muscles of the diaphragm?
7 to 11.
Does it arise from all the 12 ribs, or only a few ribs?
7 to 11. 4 ribs.
11, 12. 12 is not included. All the lower 12, 6 ribs. Okay, all lower 6 ribs on each side, both right side and left side. Their cartilaginous surface and adjacent parts give rise to the costal origin. And this portion of that fibers, they interdigitate with the transversus abdominis muscle also. That is why transversus abdominis muscle also becomes part of your respiratory function muscle. Okay, that is very important for inspiration or expiration.
Inspiration, sir.
Inspiration, sir.
Both, but importantly, inspiration, sir.
Inspiration is an active process, whereas expiration is a passive process. Just the recoil of the stretched muscles is the expiratory act. Okay, so transversus abdominis is helpful in holding the breath. Okay, when you want to voluntarily hold the breath, your abdomen also will become tight because of the interdigitation with the transversus abdominis. Okay, so when you do the breath holding test, you can place your hand on the epigastrium of the patient to see whether the transversus abdominis starts moving. That is the earliest sign that the person is starting to breathe. So you can assess the breath holding time by placing the patient's your palm in the patient's epigastric region and see whether the abdominal muscles start moving. That is the reason why this point is very important, that the lower 6 ribs which contribute to the muscles of the diaphragm, they also have a connection with the transversus abdominis. This is the applied anatomy you have to know. And the third origin is from the lumbar vertebrae. Okay, so they mainly give rise to 2 lumbocostal arches. Medial lumbocostal arch is a tendinous arch in fascia which covers psoas major muscle. Medially, it attaches to the side of the body of L1 vertebra. Laterally, it connects to the front of the transverse process of the L1 vertebra. Then there is a lateral lumbosacral lumbocostal arch, which is also a tendinous arch in fascia covering the upper parts of the quadratus lumborum muscle. That is why sometimes when you have a psoas abscess, patient may have difficulty in breathing because of this connection, or quadratus lumborum injury also can produce difficulty in breathing because of its connection with the diaphragm. And medially attached to the front of the transverse process of the vertebra L1, laterally connects to the lower border of the 12th rib. So it has got 3 attachments: sternal, costal, and lumbar. All the 3 you have to describe if the anatomy question is asked on the diaphragm. So this picture will help you to remember it easily. You have a sternal origin at the back of the xiphoid process as marked in this picture, and you have the rib or costal origin arising from the lower 6 cartilaginous and part of the bony prominence. This medial portion is the cartilaginous portion of the rib. The lateral portion is the bony part of the rib. So it arises from mostly cartilaginous and some part of the bony section of the ribs on the lower sixth costal margins. And the lumbar origin comes from the L1, L2, L3 actually on the right side and L1, L2 on the left side. And these form the ligamentous or tendinous origin. Okay? So from where do the crusts of diaphragm arise and how is median arcuate ligament formed? This is another part of the anatomy in the formation of the diaphragm. In this picture, you can see the crust. This is the crust. What is this tendinous thing which is arising from the L1, L2, L3 vertebra? This is called the crust. So this is another crust which is originating. So when they combine or when they join in the midline, that forms a arch-like thing which is called the arcuate ligament. So if you see that the right crust arises from the anterolateral surface of the bodies of the upper three lumbar vertebra. So L1, L2, L3, all these things give rise to, this is called the right crust. And the left crust is arising from L1 and L2. Okay. So these are the attachments that are happening. And medial margin of the two crura, this is the medial margin of this is the right, this is the left, both joined together to form an arcuate thing, and that is called the median arcuate ligament. And in this picture, you can see very much more clearly the names written here. L1, L2, L3 give rise to the right crust. L1 and L2 give rise to the left crust, and this is the median arcuate ligament, and this is the rib and lateral arcuate ligament, which is formed by this lateral portion of the muscle, and the whole thing is given nicely in this picture, which you can remember. And if you can reproduce, well and good, you can do that also. So where is it inserted? Now we saw the origin of the diaphragm from three structures, namely the sternal, the costal, and the lumbar or the vertebral origin. Now all this origin, all muscles have an origin and an insertion. So where is the insertion of the diaphragm, and what about and how it is different from the other muscles?
Central tendon.
It is inserted into a central tendinous portion. Very good. That is a very important thing. Normally, other limb muscles will have an origin from one end of the bone and get attached to the other end so that they can act as a fulcrum and contract. Whereas here, the muscle fibers, even though they take origin from bony structures, they get inserted into the tendinous portion at the dome or at the highest point. Okay. So insertion, the diaphragm inserts into a central tendon, and the top surface of the tendon is partially connected to the lower surface of the fibrous pericardium. So this is a very important thing. The central tendon, what is the importance of this attachment? This connection with the central tendon to the lower part of the fibrous pericardium. You can do what is called a window pericardectomy in the severe cases of pericardial effusion very easily through the undersurface of the xiphoid process. Even under local anesthesia, we can drain the excessive pericardial fluid in a small surgery called window pericardectomy. Okay. So patients who are very sick, who are unfit for any anesthesia for a total pericardectomy, you can remove the tamponade by making a small incision in the lower portion of the diaphragm and the pericardium at the central tendon portion, which is called window pericardectomy, which is an emergency life-saving procedure. Okay, and the muscle fibers arising from the right crust traverse up to the left side and encircle the orifice of the esophagus in a sling-like loop. If you have seen in the earlier picture, I'll just go back to the picture. You can see this is the right crust, and this fleshy portion is the muscular portion of the right crust, and it goes like a sling, and it acts to constrict the esophagus to prevent what condition?
Hiatus
Hernia,
hernia.
sir, gastric hernia, sir.
Reflux,
Hiatus.
correct. It
Oh,
can prevent
GERD.
acid reflux. Okay, so not only the lower esophageal sphincter is important, this right crust musculature is also very important to prevent the esophageal reflux. Okay, so that is the anatomical importance of this right crust, which also helps apart from the gastric lower esophageal sphincter. This also contributes to the uh, prevention of esophageal reflux. So these fibers act as a sphincter and lightly assist in preventing regurgitation of stomach contents into the thoracic part of the esophagus. So if the patient has got diaphragmatic palsy, then there is a chance that the patient can have, unless his lower esophageal sphincter is working well, there is a chance that he can, under anesthesia, he can regurgitate and aspirate. So this is a very important point, where if a patient with a phrenic nerve palsy, with a diaphragmatic palsy comes for surgery, you have to be very, very watchful in looking for or preventing this regurgitation happening. And see, this is the again the picture to show the same things in the work. So why diaphragm is asymmetric in structure? You see a picture of your chest X-ray in most of them, all of you would have seen. Which side is higher and which side is lower? The
Right
diaphragm.
Higher,
Right
sir,
side
because
is
the
usually high.
Right side will be the dome of the right side of the diaphragm will be always at a higher level compared to the left side of the diaphragm. Why?
because of liver, sir.
The liver is there under the right diaphragm, so it is a larger structure. So it pushes the or keeps the right diaphragm until a higher level. Is there any other reason why the left diaphragm is at a lower level? Any structure contributing to that?
Heart, cardiac.
Yeah, excellent.
Pushes.
The heart diaphragm is asymmetric, with the left side slightly more inferior to the right side, chiefly because of the presence of liver located on the right. And the left side may be partially inferior, located because they were pushed by the heart. So the heart is trying to push the left side diaphragm, and the liver is pushing the right side diaphragm up. So there is an inequality. If they do not normally, in normal X-rays, they should not be at the same level. The right diaphragm should be higher and the left dome should be lower. So this is the picture which shows here. You can see the right diaphragm at a higher level pointed here, and this is the heart which is pushing the left diaphragm downwards. So you have the asymmetry of the diaphragmatic surface. Now we saw three major structures piercing through the diaphragm, namely the esophagus, IVC, esophagus, and aorta in that order from above downwards. And there are some minor structures which also pass through the diaphragm. Can you name a few of the minor structures?
Foramen of Morgan.
Foramen of Morgagni is an opening. What are the structures which are
Nerve,
passing through?
vagus nerve,
Vagus, very good.
asagus,
Thoracic duct, somebody said.
Thoracic duct and
duct and asagus veins.
vein.
Okay. So there is a lesser aperture of right crust which permits lesser and greater splanchnic nerves. So this lesser and greater splanchnic nerves, they travel through this aperture in the right crust, that is the portion arising from the L1, L2, L3. And there is an aperture in the left crust which permits semi-azygos vein and lesser and greater splanchnic nerves, part of them also on the other side. The sympathetic trunk also runs posteriorly below the medial lumbocostal arches. And foramen of Morgagni is found on the areolar tissue between the sternal and the costal part of diaphragm. What is the importance of this foramen of Morgagni? Consists of a superior epigastric branch of external thoracic artery and lymphatics of the abdominal wall. Rarely can you get a herniation through this.
Yes, sir.
Yes, sir.
You can get an
Spigelian
abdominal
hernia.
content passing through. You can get a
Congenital inguinal hernia in posterior lateral
Ah.
side.
very good. You can get here. This is a very rare occurrence of hernia which can occur through this. And the medial and lateral lumbocostal arches contain areolar tissue. When present, separates the superior and posterior surface of the kidney from the pleura. Okay, that is another important thing that is the diaphragm is causing. Now, what major structures pass through the diaphragm and what level? This is another important point which you should write. And somebody has already answered. At what level does IVC enter the thorax from T8,
Esophagus
T10, and
T8.
T12? Okay, these are the three things. So the mnemonic to remember is I8, 10x, and 12. And the 8 is the homophone to remember 8. So instead of 8, you say 8. So I is standing for IVC, inferior vena cava at 8. 10x E for esophagus. So at T10 level, esophagus is going, and A aorta goes at 12, T12. So I8, 10x at 12 with a mnemonic which you can remember. I8 stands for inferior vena cava at T8, 10x, that is T10, you get the esophagus US spelling, and at T12, aorta enters the thoracic cavity. I mean, abdomen from the thorax. Whereas esophagus also is coming from the thorax into the abdomen. IVC is the only structure connecting from the lower down to the towards the heart. So T8, T10, and T12. And this aortic hiatus lies anterior to the body of the T12 and vertebra between the pleura. It allows the passage of aorta and also thoracic duct and azygos veins. So it is not only the aorta which is passing at T12 level, it is also the thoracic duct and azygos vein. And this picture you can easily see, IVC is here, esophagus is here. This is the sling formed by the right crust. You can see this. And this is the aorta coming through the median arcuate ligament along with thoracic duct and azygos vein. And these are the psoas muscle and quadratus lumborum muscle, which forms part of the, from their fascia, these fibers are arising. So you can see that also. This is the lateral arcuate ligament, this is the medial arcuate ligament. So all these things are arising from this. This picture is also worthwhile remembering. Now, what is the nerve supply to the diaphragm?
Phrenic nerve. Phrenic nerve. Motor is phrenic nerve.
Motor nerve, you have motor and sensory.
Sensory, central part.
Sorry, what is the blood supply to the diaphragm? Any anatomy question? We'll have to first say about the origin, insertion, the structures passing through, the blood supply, nerve supply.
Intercostal.
Inferior phrenic artery.
Musculophrenic artery, which is a branch of internal thoracic artery. One, there are actually 4 supplies. The second is superior phrenic artery, which is a direct branch from the aorta, and the lower 5 intercostal arteries and subcostal artery, and inferior phrenic artery again from either aorta or celiac artery. Okay, so there is a being a big structure and a muscle which is working constantly, it requires a lot of blood supply. So you can see there are 4 major blood supply: musculophrenic from internal thoracic artery, superior phrenic artery, which is a direct branch from aorta, and then the intercostal arteries, lower 5 intercostal. Even though origin is from lower 6 intercostal ribs, we have 5 intercostal arteries and subcostal arteries supplying the blood, and inferior phrenic artery and or the celiac artery gives the blood supply. Coming to the nerve supply, motor nerve supply is from the right and left phrenic nerves, which have a root value of C3, C4, C5. Okay, C3 to C5 it is written here. Actually, it is C3, C4, and C5, which is the main motor supply. And sensory supply
It's also phrenic nerve in central part.
Same phrenic nerve.
same semicnerve and also
And the lower
phrenic nerve
costal.
is the parietal pleura and the peritoneum covering the central surface of the diaphragm. So this portion is by the phrenic. But the lower 6 intercostal nerves also supply the periphery of the diaphragm. So the central portion alone is supplied by the phrenic nerve, the parietal pleura and the peritoneum, whereas that is both on the upper side and on the lower side. The lower 6 intercostal nerves supply the periphery of the diaphragm, and both non-myelinated and myelinated phrenic sensory nerves modulate respiratory output during each breathing cycle. So this sensory supply is important to feel the respiratory act. And activation of the phrenic afferents does increase significantly as the diaphragm continues to work and become develops fatigue. That is, when you do a vigorous exercise, you start panting and you feel the difficulty in breathing. All that is because that is conducted by the phrenic afferents. And once the phrenic afferents are activated, they also modulate the sympathetic motor outflow. There is an interconnection with that. So phrenic afferents also contribute to the somatosensation of the diaphragm. So that is the one which makes you become aware of your breathing while you are awake. Okay, so that is how the sensory supply is very important. And the vena cava trunk, which lies at the level of T vertebra, the central level, they also pass some branches of the right phrenic nerve. Whereas left phrenic nerve passes in front of the aortic arch, comes down and pierces and supply the undersurface of the diaphragm. Now coming to, after knowing all these things, what is the applied anatomy of diaphragm? Why we should know about this?
Diaphragmatic hernia.
Clinical conditions where we have to know why we have to know about this. In what way this
Diaphragmatic hernia.
Diaphragmatic hernia may be congenital at birth. Very good. So it is one of the pediatric emergencies. In the theory exam conducted, they asked about, I think, gastroschisis, which is one of the pediatric emergencies. Whereas diaphragmatic hernia is also one of the pediatric emergencies. So just like your tracheoesophageal fistula or omphalocele, this is another condition where you may have to operate early to prevent the child going in for respiratory failure and associated complications. Okay. Anything else? Okay. So the diaphragm has many other roles besides respiration. It acts as a barrier between the thoracic and abdominal cavity and prevents herniation of abdominal organs into the chest. And this herniation can happen, as I told you earlier, as a congenital diaphragmatic hernia in the newborn, or it can be caused by penetrating or even blunt trauma, which can injure the diaphragm. Okay, and irrespective of the size of the tear, the muscle must be repaired. The tear in the diaphragm must be repaired as soon as possible to prevent herniation of abdominal organs. Okay, so it is a quasi-emergency situation where you have to operate and correct the diaphragmatic injury. When the muscle is irritated, it can result in sudden contractions. It can be uncomfortable, and that is called hiccups. And hiccups sometimes can occur during general anesthesia when the patient recovers or the muscles recover from the effect of muscle relaxants. Sometimes it may be very distressing, especially when they do abdominal surgical procedures and your controlled ventilation, you are given muscle relaxant and the effect wears off. With the surgeon handling the bowel structures or the stomach, you can get a involuntary contraction of the diaphragm, which results in hiccups, which may be hindering the surgeon's activity and also may be very distressing to see. So hiccups may be caused by partial recovery of the muscle relaxant, the diaphragm from the effect of muscle relaxant. When you do laparoscopic procedures under central neuraxial blockade, for example, in a very sick patient, if you want to do a lap cholecystectomy under high thoracic anesthesia, epidural anesthesia, what will the patient complain of?
Shoulder pain.
Right shoulder pain.
They will complain of shoulder pain because the undersurface of the diaphragm is irritated. Okay, so laparoscopic procedures done under central neuraxial blockade can cause shoulder pain due to irritation of the diaphragm by the pneumoperitoneum that is caused. That is why we mostly try to go for general anesthesia for almost laparoscopic procedures. How can you abolish? Supposing you want to do this under central neuraxial blockade due to the condition of the patient, can this pain be abolished by any technique?
Can change the position of the patient.
In the position, what position depends on the surgeon's access to surgery, isn't it? Sometimes they ask for the Trendelenburg, reverse Trendelenburg. Sometimes we ask for.
We have to irrigate the field at the end of the surgery wells.
You can instill local anesthesia at the very beginning itself, so that after all it is the phrenic nerve irritation which is causing this pain, isn't it? So you can ask the surgeons to instill 0.25% bupivacaine 10 ml at the very beginning of surgery and give a little head down tilt so that local anesthetic will go and apply on the surface, under surface of the diaphragm, and that will block the nerve. Okay, so that way you can abolish this pain. That's one of the practical tips that you can remember. And there are, of course, as you said, slow fibers and fast fibers, which are equal proportion in adult diaphragm, but intercostal muscles contain higher proportion of fast fibers. What is this slow and fast fibers? What is your idea about this?
Slow fibers are non-myelinated fibers.
No, this is about the muscle, not the nerve. Slow fibers and fast fibers mean it is
Depending
the
on
type of muscle. So
Ox-
they are
better.
called slow oxidative and fast oxidative
Fast.
fibers.
Fast
So the
fibers
fast fibers have
get
got
fatigue
more,
usually.
utilize more energy, they require more, they act faster and become fatigued faster. Whereas the slow fibers, they consume less energy and they can work for a longer time. So people who train in athletics and other sports activities, they develop or they have more slow fibers, so they don't become fatigued or though they don't become breathless. That is, by training, you can improve the activity of the slow fibers, whereas fast fibers are the ones which utilize more of energy and then they can become tired faster. Okay, so if you have slow fibers, you will be tolerant to more strenuous exercise without becoming dyspneic or without having difficulty in breathing. Now, what are the causes of phrenic palsy and what is its implication? What are the conditions where a patient can develop a phrenic palsy?
Interscalene block.
Very good,
During
excellent. Interscalene block. Then any other
Post is
block?
cervical.
Thoracic, cervical.
Post neck and the thoracic surgeries.
Surgery, that is trauma. Yes, that you can do traumatic. Yeah. But in block, other than interscalene, which other block also can cause phrenic nerve palsy?
Infraclavicular.
Block you can give for thyroid surgery. Deep cervical block. Okay, deep cervical block is another one. The superficial cervical is given at this subcutaneous level, at the platysma level. Whereas deep cervical block is given to block the C2, C3, C4 for thyroid surgeries. That also can result in the local anesthetic can travel down, and after all, the root value we know is C3, C4, C5. So if all these three roots are blocked, your phrenic nerve will get blocked. So phrenic nerve palsy can occur during trauma by surgery or during blocks like interscalene or stellate ganglion block or deep cervical block. Stellate ganglion block, when do you use stellate ganglion block? What is the indication for stellate ganglion? This is one of the short note question you can get in your theory paper. What is stellate ganglion and what is its indication for blocking that? What is CRPS?
A chronic regional pain syndrome.
Chronic or complex regional pain syndrome of the upper limb. Okay, so patient will have severe pain even for a non pain causing stimulus. Okay, so hyperalgesia, allodynia, all these things can be controlled or cured by giving a stellate ganglion block. Okay, it is a sympathetic block. formed by the lower sympathetic chain of C5, C6 with the first thoracic. Okay, so that is the stellate ganglion block and deep cervical block, which also. So, what will happen if the phrenic nerve is? How will you identify the phrenic nerve palsy from the X-ray chest? What will happen to the level of the diaphragm on the side of
Higher
palsy?
The diaphragm.
It will get elevated further. Okay, so whether it is on the right side or right side, normally it is slightly higher, but if with the right side phrenic nerve palsy, then the diaphragm will even rise much more higher than the left side. Or if the left side diaphragm phrenic is avulsed or injured, the left diaphragm will rise more than the right diaphragm. Okay, that is how you try to identify. So phrenic nerve will cause elevation of the diaphragm, and that will result in reduction of the volume of the thorax. So it will act like something like a restrictive lung disease. And you can see this is the before the paralysis. This is a normal level. You can see the right dome is slightly higher and the left dome is slightly lower. Once the patient has a right phrenic palsy, you can see this diaphragm has elevated much more. You can see the ribs going through that. So the level is, whereas the left remains at the same level, the right gets elevated. So this much of reduction in the volume of the thoracic cavity will happen. So the lower segment or lower lobes cannot expand properly, and that may result in atelectasis and the decrease in saturation or pneumonic consolidation can happen. So why should you not give bilateral interscalene block or deep cervical plexus block?
Chance of hitting the phrenic nerve is more common.
So both the you should not give, both the sides can get palsy. So that is how the it should never be performed on both sides, and especially in patients with the compromised respiratory function, you will be very careful while giving interscalene block. Even hemidiaphragmatic palsy will cause severe respiratory distress in patients who are known asthmatics or known COPD patients. If you try to give interscalene for a upper limb surgery in those patients, you have to be very careful to see that you block only from C5 to T1 and don't block the C3 and C4. Okay, so that is a very important precaution you have to see. Sometimes purposely we can do what is called unilateral phrenic nerve avulsion for intractable hiccups. So sometimes patients come with hiccup. I have seen in my earlier days, a patient having hiccup for a week continuously and becoming so exhausted and tired, and you purposely block or use to damage or even cut the phrenic nerve on one side in those patients to stop the hiccup. But this is not practiced anymore, but of historical interest, you can remember that. Okay, so that much about anatomy of the diaphragm. So you have to know about the origin, insertion, structures passing through, when the nerve supply and blood supply and the applied anatomy. All these points are written. Your answer will be complete about the question on the anatomy of the diaphragm and its implications. Now we go to a part of physiology about the PEEP, which we have not discussed. So what is positive end expiratory pressure and how does it happen? Positive end expiratory pressure, which is also called commonly PEEP. That's a short acronym. What is the what exactly you mean by positive end expiratory pressure? What will happen during normal respiration? What will be the pressure at the end of expiration? At the alveolar level, what will be the pressure at the end of a normal respiration? It will equal to what? And at the end of expiration, what will be the normal alveolar pressure and what it will equate with? It equates with atmospheric pressure, isn't it? So we are breathing at atmospheric pressure. So we, by creating negative pressure, which we saw earlier, which the diaphragm does by contracting, we suck in the air, or we inspiration, the air is going in from the atmosphere up to the alveoli. And while expiration takes place, the muscles recoil and constrict so that the alveoli collapse and all the air goes out. So the alveolar pressure becomes equal to atmospheric pressure. Okay. So normal inspiration, negative pressure created only sucks in the atmospheric air. During expiration, the recoil or collapse of the lung and the chest wall, they cause expiration of the air, and the alveolar and the airway pressure becomes equal to atmospheric pressure. Okay, this is what is happening. But if you convert this normal physiology by application of pressure at the end of expiration, then it becomes, instead of equaling the atmospheric pressure, it becomes more than the atmospheric pressure, which we call it as positive end expiratory pressure. Is it clear?
Yes,
So
sir.
positive end expiratory pressure is the positive pressure that will remain in the airway at the end of the respiratory cycle and is greater than the atmospheric pressure in mechanically ventilated patients. So we purposely apply an extra pressure to prevent the alveolar pressure becoming equal to atmospheric pressure. Then that is called the positive end expiratory pressure. Okay. So PEEP can be a therapeutic parameter in the ventilator. If you set it, that is called extrinsic PEEP. Or it can be a complication of mechanical ventilation with air trapping, which is also called auto PEEP. So who are the people who will develop auto PEEP or intrinsic positive air trapping?
Obstructive lung diseases.
COPD patients, obstructive lung disease patients, not restrictive. Obstructive lung disease patients
Obstructive.
only will have, because they are not able to exhale all the air completely. They go on accumulating, and that causes an increase in PEEP. So PEEP can be of two types. One is called extrinsic PEEP, and the other is called intrinsic or auto PEEP. So these are the two types of PEEP that we can. Extrinsic PEEP is what we hydrogenically keep in the ventilator, whereas extrinsic PEEP is caused by the pathology that is there in the lung. That is called auto PEEP. Okay. Now, how PEEP helps respiration? Which gas law is applicable to this? What is the role? Why we normally use this PEEP when we mechanically ventilate patients? All of you would have experienced, those who have worked in
Prevent
ICU.
alveolar collapse.
Prevent airway collapsing. Very good. Alveoli are kept little open all the time instead of collapsing completely. What is the advantage of doing that? What do you increase by doing that?
It increases effort.
CD residual.
It pushes the gas in the FRC into the blood, isn't it? This positive pressure will help to push the gas from which is present at the FRC level, functional residual capacity level, into the blood to improve the oxygenation. So which gas law is used for this? You apply more pressure to make a gas go into the bloodstream. Which law is applicable? Hyperbaric therapy. Which law is applicable?
Gay-Lussac.
Huh? Not Gay-Lussac. I have given you a clue also. Hyperbaric therapy works on which law? Henry's law. It is called Henry's law. Okay. Extrinsic PEEP can be used to increase oxygenation. How does it do? By Henry's law, the solubility of a gas in a liquid is directly proportional to the pressure of the gas above the surface of the solution. Okay. That is, this is the same law which is applicable for hyperbaric therapy also. So if the solubility of a gas in a liquid is directly proportional to the pressure. So when you give extra pressure by extrinsic PEEP, the oxygen in the FRC air or whatever percentage of oxygen you are giving, that will be pushed into the bloodstream or capillary blood that is supplying the alveoli, and that will improve the oxygenation. So this in turn increases the solubility of oxygen and the ability to cross the alveolar capillary membrane and increase the oxygen content in the blood. So the one of the then extrinsic heat also improve the ventilation perfusion mismatches by causing more oxygenation. By this method, it improves the VQ performance. That is, a ventilated lung is able to take more oxygen by if there is adequate perfusion. And the application of positive pressure keeps the alveoli open or the smaller airways open or split them from collapsing and decreasing atelectasis. It also prevents the atelectasis by improving alveolar ventilation, which in turn decreases the VQ mismatch. This is another advantage of the PEEP. One is it improves the VQ mismatch by increasing the solubility of oxygen. It also prevents the atelectasis. And extrinsic heat also significantly decreases the work of breathing. So when you are able to get more oxygen with the pressure that you apply, patient need not strain his muscles to take in more oxygen. So then way it decreases the work of breathing. So this is a very common question they ask me in the examination as a short note question. So extrinsic heat, how does it increase oxygenation? It is by Henry's law. And by increasing oxygenation, it improves the VQ mismatch and it also decreases atelectasis and it decreases the work of breathing. These are all the points that you have to keep in mind. What are the complications? We talked good about PEEP all the time, but is PEEP so safe? Can it be used without proper application of your physiology? We are altering the physiology completely. So there must be some complications that can be produced by our trespass in the normal physiology. So what are the complications that can be caused by PEEP?
They can reduce the stroke volume and reduce the cardiac output.
Very good. It will, as we saw first in the beginning itself, the negative pressure created is not only important for taking the air into the lungs, but it is also important for the venous return to reach the right atrium by the negative suction pressure. So when that is abolished, the venous return will be decreased. So patient's cardiac output is likely to come down. So if the patient is not in a healthy cardiac state, or if he is dehydrated and hypovolemic, and on top of it you put in a PEEP and prevent the venous return, patient can suddenly collapse. Cardiovascular instability can suddenly occur dramatically after instituting the PEEP. So before that, we should first make sure that the patient is in a euvolemic state and he has got a normal cardiac function. That is one point. So normal respiratory physiology works as a negative pressure system. When the diaphragm pushes down during inspiration, negative pressure in the pulmonary cavity is generated, and this is sucked the air into the lung. The same negative intrathoracic pressure decreases the right atrial pressure and generates a sucking effect on the IVC, increasing the venous return. This is the normal physiology which we have to remember. We want to talk about the complications of PEEP. So the application of extrinsic PEEP changes this physiology. And this increase in right atrial pressure decreases venous return, generating a decrease in preload. Less blood in the RV, that is right ventricle, means blood reaching left also will be low. So less blood and decreasing cardiac output will happen. And the decreased preload means the heart works at a less efficient point of Frank-Starling curve, generating less effective work and further decreasing cardiac output, resulting in a drop in severe mean arterial pressure. A severe drop will happen. So this has to be compensated by increasing the SVR by the patient. So if the patient is already in a shock state, like your distributive shock, which is caused by sepsis or neurogenic or anaphylactic shock, and they cannot compensate by increasing the SVR, they will have a dramatic cardiovascular collapse. So the effect on RA pressure and venous return sometimes may be beneficial for patients in cardiogenic pulmonary edema. We purposely institute PEEP for patients with cardiogenic pulmonary edema. So how does this will help because the venous return is decreased, the pressure or the flow into the lungs is also decreased. Right ventricular output is decreased. So cardiogenic pulmonary edema is mainly because of the back pressure effect and the fluid leaking out from the capillary into the alveoli. And that is how the cardiogenic pulmonary happens. So if the blood volume in the pulmonary circulation is reduced, the amount of edema fluid collecting in the alveoli will also decrease. So that is the method or mechanism by which the cardiogenic pulmonary edema is treated by application of a PEEP. So in patients with volume overload, decreasing venous return will have a dual benefit. What are the dual benefits? It will decrease the preload, that will place the LV at a moderate efficient workload, possibly increasing cardiac output and improving pulmonary edema. Although a very high PEEP directly does not improve the LV function. Decrease in venous return means less blood pumped into the RV and less blood goes into the pulmonary circulation. So that will also help to reduce the pulmonary edema. So it increases the cardiac contractility at the same time reduces the pulmonary edema by reducing the volume into the pulmonary circulation. Now, can PEEP be applied to patients who suffered a stroke or a subarachnoid hemorrhage? Sometimes you get patients who are having head injury with a SDH or a subarachnoid hemorrhage, or patients who have suffered a stroke. In those patients who require ventilation, can PEEP be applied?
Depending on the hemodynamic stability.
No, but what point you have to keep in your mind? Your point is right, but what is the correct explanation you have to say? Hemodynamic status should be normal for any patient to apply PEEP. But more so in stroke or subarachnoid, how will you explain the mechanism? How PEEP can worsen the cerebral circulation?
So we have to maintain the cardiac output to the perfusion to the
maintain CPP, cerebral perfusion pressure. Okay, extrinsic PEEP effect on cardiac output and MAP is important to consider in patients who have to have a normal cerebral perfusion pressure. What is what is the normal cerebral perfusion pressure? How is it calculated?
mean arterial pressure minus
Mean arterial pressure minus the intracranial pressure, ICP. Okay? So patients with stroke or subarachnoid, ICP will be raised. And if you decrease the mean arterial pressure by applying PEEP, then the CPP will drastically reduce and you will worsen the ischemia that is already happened there. Okay, so that is the reason why you have to be very, very careful in application of PEEP for patients with subarachnoid hemorrhage. So in cases of disturbed cerebrovascular autoregulation, the decrease in MAP can directly affect the cerebral perfusion pressure, causing adverse effects. So what are the other adverse effects caused by PEEP? Apart from this effect on cardiovascular system, reducing the venous return and causing a decrease in cardiac output or affecting the CPP in head injured patients or patients with intracranial pathology, what are the other adverse effects caused by PEEP?
They can significantly reduce the GFR by reducing the renal perfusion.
Okay. Long-term effect. That is not an immediate effect, but a long-term effect definitely. That is again because the MAP and the cardiovascular stability is decreased. That is why GFR gets reduced because of the impaired renal perfusion. That is a long-term effect of prolonged PEEP ventilation. But more than that, includes barotrauma. This is the first one we have to always think of. As we start increasing the PEEP, suddenly you may find patients quickly desaturating and air entry decreased on one side, patient going in for tachycardia, hypotension. First thing we have to think in terms of barotrauma because it keeps the alveoli open and increases the pressure. Alveoli which are weak, there is maybe a small bulla which can get ruptured, and that will increase the intrathoracic accumulation of air and cause a barotrauma and sudden tension pneumothorax can develop. So that will interfere with the hemodynamic functions and also will if you are doing hemodynamic measurements with right heart catheters, PEEP will alter that. So in patients who have a invasive monitoring done, PEEP will definitely affect the results. And what are the basic principles we have to apply to all modes of ventilation where we use PEEP? As we already saw, with that we can answer this question. What are all the basic principles? I've already told you the few points how to keep the hemodynamic system stable. So start low at a lower peak pressure and increase as the patient tolerates the PEEP. Set to the point of comfort and desired oxygenation. So don't start with a high PEEP of say 20 centimeters or 30 centimeters. Always start with high, then increase to 7, 8, 10, 12 like that. Gradually increase and make sure that the patient is hemodynamically stable, and it also improves the oxygenation if the patient is hypoxemic. So that is the first and foremost law that you have to follow. Second, constantly check the plateau pressures to see whether the barotrauma is occurring or not. So first indicator to show that the patient is going in for higher pressure inside the respiratory tract is the plateau pressure will go on increasing. So watch the graphics and see whether the plateau pressure is staying well below 30 centimeters of water. As a general rule, keep the plateau pressure below 30 centimeters of water and follow the mean arterial pressure if you are dialing up or down the PEEP. So if you are especially increasing the PEEP, make sure the patient's mean arterial pressure is maintained at the same level and is not decreasing. That is a very important point to assess the cardiovascular effect. And when extubating patient with cardiogenic pulmonary edema who received extensive PEEP, that is from the mechanical ventilator, consider its effect. Suddenly you withdraw the PEEP, then the patient will have increased venous return, and that may cause a fresh pulmonary edema. So any patient who has had mechanical ventilation with PEEP to control the pulmonary edema, during weaning you have to again gradually decrease the PEEP and make sure that the patient is able to still has a clear lung without any fluid accumulation, and then only plan for extubation. Otherwise, you will have a new pulmonary edema that may be need for reintubation. And what is the protocol that is used as a guide for application of PEEP? Actually, PEEP was introduced in which particular condition to improve the oxygenation? All of you would have seen it in COVID times.
CPAP.
CPAP is a one mode of ventilation, but the question is why people thought of employing PEEP, in which particular pathological condition of the lung they wanted to use PEEP to increase the oxygenation of the patient.
Atelectasis.
ARDS. COVID times we all are seeing, patients developed ARDS like picture, isn't it? Acute respiratory distress syndrome. So in that situation, you wanted to improve the oxygenation without increasing the FiO2 by increasing the expiratory pressure. So based on that only, we found all the protocols. So that is called ARDS net protocol. ARDS stands for Acute Respiratory Distress Syndrome net protocol, provides clear guidance on how to titrate PEEP and FiO2. Okay, so with the lower FiO2, we want to improve the oxygenation because high FiO2 itself is toxic. This is the reason why. So ARDS protocol is the one which gives the guidelines for application of PEEP. So if they ask you write a short note on PEEP, you will have to first start explaining what is PEEP and how does it differ from the normal physiology. Then you must explain what are all the advantages of PEEP, how it improves oxygenation, weak mismatch, prevention of atelectasis, all that points. Then you have to go explain the complications or disadvantages of PEEP and what are the contraindications or caveat you have to use for application of PEEP and what are all the other side effects and how do you apply PEEP? What are all the basic principles you want to apply? You write all these points, I think your answer will be complete. Okay. Now, auto PEEP will go to, because this is a pathological condition. All what we talked about so far is the extrinsic PEEP applied in the mechanically ventilated patient. Now, what is auto PEEP or intrinsic PEEP, and how is it caused, and what are its effects? So this is a very important point we have to know, because we may be getting cases, discussion on COPD cases given to you in the practical examination for patient with COPD coming for lap cholecystectomy or a hernia surgery or a trauma, like situations may be given. So we have to know what is the importance of auto PEEP or intrinsic PEEP. As we already saw, it occurs in patients with COPD, isn't it? Auto PEEP can be a complication of mechanically ventilated patients, or it can be occurring normally because of the disease. So usually passive exhalation will permit complete emptying of the air in the lungs until lung pressure equalizes with the atmospheric pressure. This is a very basic point that all of you should remember very well. At the end of normal respiration, the lung pressure should equalize atmospheric pressure. But in some cases, the lungs may not completely deflate, leaving air trapped inside the lung at the end of exhalation, which generates a positive pressure that remains in the lung. So patients have a higher pressure than the atmospheric pressure inside the lungs at the end of expiration. This pressure is also called the auto PEEP or intrinsic PEEP. So when this pressure process repeatedly happens during each respiratory cycle, the amount of air trapping increases with each breath, which will consequently increase the intrathoracic pressure in the very pathological or high conditions, resulting in right atrial and decreasing venous return, causing hypotension, as well as increasing the plateau pressure, that is intraalveolar pressure, causing barotrauma. These are all the effects that can happen because of that, which we already saw. And this increased air trapping will also make it harder for the patient to breathe, increasing the work of breathing, which will increase oxygen consumption and also increase carbon dioxide production, thereby increasing the need for ventilation, increasing the patient's respiratory rate, and worsening auto PEEP in a vicious cycle. So that is why COPD patients, severe COPD patients always have a tachypneic and first mouth breathing, and all those things happen because they have to increase their work of breathing. Now, what factors lead to auto PEEP? Mainly airway inflammation and mucus plug generate dynamic airflow obstruction. So any form of COPD, obstructive airway disease, as a forced expiratory effort will increase the pressure around the airway, leading to its closure, and the plugs are inflamed area, trapping air in the alveoli that are dependent on the airway. So this is how air trapping gets happened. Second thing is high lung compliance, as in chronic COPD patients, who are especially emphysematous patients, who are similarly the airway leak, lack scaffolding and stay open during forced exhalation, leading to dynamic airway collapse and air trapping. The first thing is airway inflammation and mucus plug generation. Second is the lung compliance increase as it happens in emphysematous patient. And third is high tidal volume ventilation. If you use high tidal volume for mechanically ventilated patients, that also will cause auto PEEP, because the amount of volume that you pump in will not be completely exhaled out. So it remains inside the lung, causing increase in the pressure as well as the volume of the air. So these are the three things which lead to auto PEEP: airway inflammation, lung compliance increase, high tidal volume ventilation, and also high respiratory rate. If you set the respiratory rate in the ventilator, this is how mechanically you can generate this problem. Even in a normal lung, if you keep the respiratory rate high, there is very short time for the exhalation to happen. So expiratory time is reduced, so you will have more of air accumulation in that. And the slow inspiratory flow rate generating high inspiratory to expiratory time ratio. That is, when you get the inspiratory flow rate time very slowly, it takes longer time for the inspiration to deliver the gases. So what happens? Expiratory time automatically gets reduced. So high respiratory rate, by decreasing the expiratory time, and also slow inspiratory flow rate also increases or decreases the expiratory time, which all result in accumulation or air trapping. So how do you suspect autopnea? If you have a ventilator which shows the graphics, how do you find out whether there is a patient? Initially, you keep to say, let us say, we keep a PEEP of 5 centimeters. And if you look at the graphics, what will be you see? And if supposing patient starts developing auto PEEP or intrinsic PEEP, gradually his air trapping increases and the pressure goes up. How do you find it out from the ventilator graphics?
The expiratory curve goes beyond the start of inspirations.
Very good, excellent. And also, if the curve with the graphics fails to go back to 0, then it is a sign of air is being trapped. And see, you can see here, this is how the whole thing. This is the inspiration. This is the expiration. This is the normal pattern. You can see the dotted line is the normal pattern. So in a normal patient, after inspiration, the expiration comes and touches the baseline. Okay, this is the normal flow. But in a patient who starts getting air trapped, what happens? You can see this is the continuous line which goes there, goes beyond and does not touch the baseline, or it does not come back to 0. So there is always a difference. Before that, inspiration starts. So this whole green area is the inspiratory phase. So the inspiration starts even before the expiration comes to the baseline. So this much of air trapping or auto PEEP is unsafe. So this picture, you can see gradually it goes on increasing. The curve does not come to the baseline at all. So if you see this in the flow volume loop, then of the graphics, you will know that patient is developing auto PEEP. This is a very, very important point. All of you should remember very well, especially if you are going to work in ICU settings or intensive care. You must know when to reduce the PEEP and make the patient prevent this auto air trapping occurring. So increasing plateau pressure on the ventilator also is another thing which will tell you that. And active exhalation with the patient as seen by the use of accessory muscles of respiration during exhalation. So if you watch the patient clinically, they will start developing these neck muscles and the intercostal muscles, they will all start acting. So a patient who has been smoothly breathing on the ventilator, if you suddenly start using his accessory muscles, that means he is trying to exhale the excess air that is accumulating inside the lung. So, and because of the increase in airway, you will have a drop in blood pressure because the venous return will be reduced and patient will have low cardiac output. You will have a drop in blood pressure, and patient will have long expiratory times. As you see, it is not touching the baseline quickly like normal. So patient has got a long expiratory time. So how do you treat? Supposing you find this in the ventilator graphics, you find these changes. How do you act? How do you have diagnosed that they are trapping and auto PEEP is occurring? So how do you treat that? Have you not been taught in the ICU in your whether this is a very common complication that can happen, isn't it? So how do you treat an auto PEEP? You will
We
have
can
to
increase the expiratory times.
very good. You can increase the expiratory time more than the inspiratory time, altering the IE ratio. Very good. Number one. Anything else? Can you reduce the tidal volume? Can you reduce the respiratory rate? All these things what already we have seen, isn't it? So in most extreme cases, if the patient is in respiratory distress and shock, first thing is disconnecting the patient from the ventilator. Sorry, and allowing enough time for exhalation before manually bagging the patient is a quick life-saving measure. So if this has been neglected, this auto PEEP accumulation has been neglected and patient has gone into a state of respiratory distress and shock, simply disconnect the patient from the ventilator and allow him to breathe through the endotracheal tube at the atmospheric level. That is the first quick life-saving measure in extreme cases. And assuring enough time for exhalation is all that air can go out is the most important principle in the treatment of auto PEEP. Okay, this is what you have to basically understand. So increase the IE ratio from 1:3 to even 1:5. Normally 1:2 is the IE ratio. You allow 1 minute or 1 second in the case, I mean 1 part for inspiration, you must give 2 parts time for exhalation. So that expiratory time can be increased even to 3 or 5 times more than the inspiratory thing. And increasing the inspiratory rate from 60 to 100 liters will assure fast delivery during inspiration, lending more time for exhalation. So this slow inspiratory flow should be changed to fast inspiratory flow so that you have more time for exhalation, because the inspiratory delivery will happen faster. And decrease the tidal volume. So if you are giving 10 ml per kg, reduce it to 6 ml per kg. Normally we recommend only 6 ml per kg, as an initial tidal volume itself. So if you are giving more than 6 ml, try to reduce it. And decrease the respiratory demand by decreasing the CO2 production. So make sure that the patient is not receiving too much of carbs and other dietary supplements to produce more carbon dioxide. So make sure that the decreasing carbon dioxide, because if you produce more carbon dioxide, you require more respiratory effort to eliminate that. So by other means, you can reduce the CO2 production itself. Sorry. Now these are all the points that you have to remember with regard to PEEP extrinsic and intrinsic PEEP. The next point, which is commonly asked in the examination as well as the short note question, is what is Haldane and Bohr effect in respiratory physiology?
Haldane effect describes increased capacity of blood to carry carbon dioxide.
Blood to carry carbon dioxide?
No, sir. Affinity of hemoglobin to oxygen.
Oxygen at which level? At the tissue level or at the lung level?
At the tissue level. No, at the lung level, sir.
See, don't, this may be looking frighteningly difficult question, but very, very easy and simple question. It depends on, this is a effect described by one Dr. Haldane and one by Dr. Bohr about the relationship between the hemoglobin, its affinity for oxygen and carbon dioxide. This is the basic thing that you have to understand. The Haldane effect and Bohr effect, they describe the affinity of hemoglobin for oxygen and carbon dioxide. Now, Haldane, the spelling is Haldane, Haldane. So this L, you remember, it happens at the lung level. At lung level, what do you want to do when the hemoglobin brings a lot of carbon dioxide from the periphery? After the oxygen has been utilized by the mitochondria and the aerobic metabolism has been going on, it results in the production of carbon dioxide and water. That carbon dioxide has to be eliminated. So it has to be brought to the lung to exhale from the body into the atmosphere, isn't it? So the CO2 that is brought to the lung is eliminated, and once the CO2 is given up, oxygen is avidly taken up by the hemoglobin. So this effect that is happening at the lung level, where you give up the carbon dioxide and take up oxygen, is what is called Haldane effect. So Bohr effect naturally will be at the tissue level, where you have to give up the oxygen and take up carbon dioxide. Okay, so Bohr effect takes place at the tissue level, where hemoglobin will easily get disconnected from the hemoglobin and delivered to the mitochondria. And carbon dioxide will be taken up. Whereas at the lung level, the carbon dioxide is given off and oxygen is taken up for the next circulation to go on and deliver the oxygen. So, Haldane effect describes how oxygen concentrations determine hemoglobin's affinity for carbon dioxide. That is, so you can remember L for lung. At the lung level, what happens is it gives up carbon dioxide and takes in oxygen. Whereas the Bohr describes the carbon dioxide and hydrogen ion affinity for oxygen. So at the tissue level, oxygen is given up at the mitochondria to the mitochondria, and the hydrogen and carbon dioxide are taken up. So it released into the tissues. So Bohr effect at that tissue level for delivery of oxygen to mitochondria. Haldane effect is for delivery of oxygen into the atmosphere and taking up of oxygen for further supply. So this is how the arteriovenous oxygen difference, oxygenated blood, deoxygenated blood. So the Haldane effect, Haldane gives up, hemoglobin gives up CO2 and PO2 rises and binds to carbon dioxide and PO2 falls. So lower PO2, CO2 will be taken up, higher PO2, CO2 will be given out. So this happens at the lung, Haldane L at the lung. Oxygen released to the tissues, again depending upon the need for the oxygen and the increased level of carbon dioxide at the tissue level to take it back to the lung. So this is how this picture, and this picture gives you a very, very clear idea. Even though it is mentioned as Bohr Haldane, you remember this Haldane is happening at the lungs and Bohr is happening at the tissues. And if you see this, this is the hemoglobin. The red image represents the stylized hemoglobin molecules which change shape as they bind and release different products. So here the hemoglobin takes up the oxygen and gives away carbon dioxide, and also hydrogen is released by combining with bicarbonate, and carbon dioxide is produced. So both are reduced at the lung level. Whereas in the tissue level, it gives up the oxygen and takes carbon dioxide and hydrogen back to the lung. Okay, so this is the Bohr effect that is happening. This picture, if you remember, you will be able to do that. Now you find there is an acronym here, HALI. Can anyone define or expand what is that acronym stand for? The Bohr Haldane effect is also sometimes combinedly, it is called the HALI, Halley effect. What does it stand for? What does HALI stand for?
Hemoglobin affinity.
Is it Risha answering the question?
Yes, sir, I'm not sure.
Okay.
Hemoglobin affinity something.
No, if it is Risha, then it is Risha's definition. Just, I'm not just for joking. Okay,
Yes.
HALI stand for heterotropic allosteric ligand interaction. This is the sum effect of Bohr and Haldane effects. Okay, so the Halley effect, sometimes
sir.
they may, examiner may ask you what is a Halley effect. It's a heterotropic, that is different types of allosteric ligand interaction. That is the interaction between hemoglobin, carbon dioxide, hydrogen ion, oxygen. Okay, so these four things they are interacting. So this is also called the Halley effect or heterotropic allosteric ligand interaction, which is the sum of Bohr and Haldane effect. So sometimes this is asked as a short note question. So I hope you have a clear idea about this. So Haldane at lung level, Bohr at tissue level. The Bohr effect is for taking up carbon dioxide to bring it to lung and deliver oxygen to the mitochondria. Haldane, removal of carbon dioxide to the atmosphere and uptake of oxygen from the atmosphere back for delivery to mitochondria. Okay, so there is no confusion on this. Now there are some pictures I have shown here. What is shown here and why these curves are different. Now, all of you must be very familiar with this particular first diagram. What is this?
Oxygen dissociation curve.
Oxygen dissociation
Fantastic.
curve.
Oxygen dissociation curve, and this is the normal curve in the red line, and it is the leftward sheet. What will happen if the curve is shifted to the left, and what will happen if the curve is shifted to the right?
The curve shifted to right, activity of hemoglobin to oxygen decreases. There will be release of oxygen to tissues.
Very good. There will be more oxygen released to the tissues. So I always remember this as a shift to the right is right for tissues. Shift to the left is wrong for tissues. That means tissues, mitochondria will not get adequate oxygen if it is shifted to the left. So it is wrong. So don't fall onto the leftist ideas. Okay, nothing political about it, but if the curve shifts to the left, mitochondria will not get adequate oxygen. On the contrary, if the curve shifts to the right, mitochondria will get more oxygen. Tissues will get more oxygen because there less affinity of oxygen to the hemoglobin. So more unloading will happen. So patients who develop acidosis or so low pH acidosis, increase in carbon dioxide or temperature or 2,3 dpg, all these conditions will increase the delivery to the tissues to make sure that you had normal aerobic metabolism is maintained. So this is a natural adaptive mechanism. Whereas if the opposite occurs, patient CO2 gets washed out, he becomes alkalotic, or if his temperature pH becomes alkalotic, or his temperature goes down, or if his DPG levels go down, then more oxygen will be retained by the hemoglobin. So less offloading or less unloading of oxygen will happen. So tissue or mitochondria will suffer from lack of oxygen. So shift to the right is always right for the tissues. Shift to the left is wrong for the tissues. So if the mitochondria have to receive adequate oxygen, the curve should be slightly to the right. Of course, in normal conditions, it will be delivered. And this P50 is another question that they will ask you. What is there? At 50% saturation, the partial pressure will be always 27. So if it happens, that means the curve is normal. So whenever you want to find out, supposing, imagine a situation where there is this red line and blue line are not there, and you are asked to find out whether the curve is shifted to the right or left, then you draw a line from the 50th partial pressure saturation, 50% saturation, then the curve will come up to this and the partial pressure will be more, so that more delivery will happen. Whereas on the contrary, if the curve has shifted to the left, what will happen at the P50 level? The partial pressure will be less, so patient will not have adequate pressure to deliver the oxygen. So more the partial pressure of oxygen, more delivery will happen. Lesser the partial pressure, so saturation does not deliver the oxygen. It is the partial pressure, because Dalton's law of partial pressure, it always goes from an area of higher pressure to lower pressure, isn't it? So that is how you always able to deliver more oxygen. So this P50 indicates the partial pressure of oxygen in the blood as measured by the arterial blood gas analysis, which determines the delivery of oxygen to the mitochondria. Okay, so this is another point that they may ask you in the examination. And the other common question asked about this ODC curve is why it is like a S or a sigmoid shaped curve. Why it is a sigmoid?
Binding.
It is because of the
And
cooperative binding.
Allosteric binding.
Yeah, allosteric activity, and very good, excellent. What is this picture?
transport of
What
carbon.
is here is the oxygen dissociation. Here it is the
Carbon
carbon
dioxide.
dioxide transport curve. Okay, so this is more of a linear curve compared to the sigmoid shaped curve of the cystic, because carbon dioxide is carried in 3 different forms in the blood. One is it is dissolved carbon dioxide. Major portion is by the bicarbonate, and the very small portion is by the hemoglobin. Okay, so the major transport mechanism is by bicarbonate, and very small portion as a dissolved portion. Oxygen also gets dissolved in the blood, but this is the attached to the hemoglobin also is attached to some extent. So these are the 3 mechanisms by which the carbon dioxide is transported, and you find there will be always a difference in the level of carbon dioxide between the arterial and venous blood. So this difference is important because That is how you find out whether your arterial blood gas sample is of real arterial blood or venous blood, because venous blood has got higher carbon dioxide concentration compared to the arterial blood. So these are the points that you have to remember with that. Now, what is depicted in these pictures? I'm showing you a few pictures and you have to identify what is this. See all these things and tell me what is happening here. In fact, one of the questions in the this recently concluded theory exam is VQ function in the normal lung. That is ventilation, perfusion function in the normal lung. One of the questions that was asked in the theory examination. We concluded last week. What is this picture I am showing here first? I thought you will rattle off the answer immediately.
Is the west lung zones.
Excellent, excellent, excellent. West zones of lung. We have zone 1, zone 2, zone 3, which is comparing the pressures between the alveoli, the venous blood and the arterial blood. Okay, capillary side of the artery, venous side of the artery. So in zone 1, which is more, alveolar pressure is more than the capillary blood. That is the arterial blood and venous blood both are, the pressure is very much lower. Alveolar pressure is very high. That means, what is the
It is
net
ventilated,
effect?
not perfused.
It is ventilated well and not perfused well. Okay, so this
No
is
gas
almost
exit.
like a dead space or a wasted ventilation. It is a zone 1 is always a wasted ventilation because the more of alveolar pressure and less capillary pressure. When you come to zone 2, what happens?
Arterial pressure is more.
Arterial pressure is more than the
Is more than
alveolar pressure.
alveolar pressure, but the venous pressure is low only. So.
Still low. So first this alveolar pressure, arterial pressure more than the alveolar, more than the venous pressure. And zone 3 is the ideal zone where you have normal alveolar pressure, which I mean normal arterial pressure, which is almost more than the venous pressure and the alveolar pressure. So zone 3 is the ideal zone where ventilation and perfusion are almost matching each other. And where does this zone remain in our lung? In the normal patient with an upright position. Where is this zone 3? Is the base or at the apex?
Base.
Base of the
It is
lung.
more at the base. Okay.
Base
So
of
this
the
is the important point that we have to remember about the west zones of lung. At the apex, we have dead space, more of wasted ventilation. Whereas at the base, both alveolar, venous, and oxygen are
And
all
perfusion.
ideal. More perfusion and more ventilation
Perfusion,
is taking
more
place.
ventilation.
So the basal
In upright
areas are well
position.
ventilated and ventilated. And the fourth one, sometimes this fourth one is not given in some books. Only 3 zones will be described, but there is also a fourth zone which compares the interstitial pressure. This becomes important if you have a back pressure. For example, a mitral stenosis patient not able to have a normal cardiac output. There is an increase in left atrial pressure, back pressure is increasing. So there is always some amount of fluid oozing out from the capillary into the interstitial space. That will also affect the ventilation perfusion. So that becomes important only in cases where the interstitial pressure is also compared to the alveolar, venous and arterial and venous side of the capillary pressures. So some books describe zone 4 also. Okay, so this is about the west zone, which you have to write in case if they ask you about ventilation perfusion for function in the normal lung. Now this is another picture. What does it depict?
It is a
Low
volume.
volume.
Flow volume, very good. Flow volume loop, isn't it? What is
Yes.
the difference between a flow volume curve and a flow volume loop?
Loop is a closed space. With
Loop is a closed one. If both inspiratory curve and expiratory curve are joined together, it becomes a loop. Now, if you draw only this portion, which is usually the inspiratory flow, then it is called the inspiratory curve. And if you combine it or join it with the expiratory curve, then it becomes a flow volume loop. Okay. So if I don't draw this line, it is only expiratory curve. And if I don't draw this portion, it becomes only inspiratory curve. When I join both, it becomes a flow volume loop. So a loop is something which is connected in both sides. So we have a normal flow volume loop. What does this indicate? It's a miniature form of this.
Restricted.
Restrictive lung
Restrictive lung disease. Okay, you can see the same amount of air inspired. I mean, the curve is same like this, and this is also completed like this, but the total volume is very low. So in restrictive lung disease, it will be the flow volume loop will be something like a miniature of this particular normal flow volume loop. Okay, and from this we can measure peak expiratory flow rate. We can measure FEV1. We can measure the forced expiratory flow 25% and 75%. Examiners, if they give you a picture like this, they may ask you what is the significance of this FEF 25 to 75%. What is the significance?
mid-inspiratory phase.
Mid-expiratory flow rate. Yeah, that is the expansion for that FEF, mid-expiratory flow rate. But what is the significance of that? Why you have to look particularly in that in this flow volume loop pictures? When you start breathing out, what happens? Initially, you do some effort to breathe out, isn't it? Even though it is happening as a passive thing, initially there is some effort that is put into exhale the gases. But from the 25th percentile to the 75th percentile, it is effort independent. You don't have to do any effort to exhale these gases. The muscles do not have to shrink further to exhale these gases. They just like that flow out. And it is this portion which will be very much restricted if the patient is going to have a obstructive lung disease. So it will become like a scooped out or curved, shallow. So that will happen in this portion. So this is the mid-expiratory flow rate, which is effort independent. That is the explanation that we have to give. And based on that, all the capacities and values you can find out. So this is a flow volume loop which we have seen. What is this picture? You carefully watch. There is an inspiration, expiration.
Pressure, volume.
This is a relationship between the pressure and volume. Okay, lung volume and alveolar pressure, transpulmonary pressure. What happens during inspiration and what happens during expiration. So this is a pressure volume changes that happen during inspiration and expiration. What is this picture?
Compliance.
Compliance.
Hysteresis.
Hysteresis. It is also called hysteresis. What do you mean by hysteresis? What does the hysteresis mean? The inspiratory path, is it the same as expiratory path or different?
It is different, sir. Due to the presence of surfactant.
Like that, if it comes back same way, you will not get this sort of loop-like picture. Okay. So when the inspiratory path is different from the expiratory path, that is what is called the hysteresis, which shows what is called the work of breathing. Okay. Because in respiratory cycle, inspiration requires muscle effort to breathe in or suck in air, whereas expiration is a passive process. That is a basic fundamental thing all of us should always remember. So once unless you put in some effort, you have to generate a negative pressure of up to 6 centimeters of water to achieve maximum inspiration. Then the pressure again comes back to zero by normal exhalation or by relaxation. So the path of inspiration is different from expiration, which is called hysteresis. And Supposing this portion goes on increasing like this, what does it indicate? Supposing the expression takes more and more negative and becomes like this, and then suddenly the expression comes back like this. What does it indicate?
Increases work of
It is an
breathing.
increase in the work of breathing. Okay, that's all. So this picture is important to assess whether the patient is breathing normally with a normal work of breathing, or whether he is having or he is struggling to breathe with a increase in the work of breathing. So that is the importance of this hysteresis picture, which you have to understand. Okay. Now the next important anatomy question, which is very commonly and very frequently asked, is the anatomy of the tracheobronchial tree. Can you describe? Supposing this question is asked in your theory paper, what will you write for this? Anatomy of tracheobronchial tree. Please don't confuse it with bronchopulmonary segments. That is a different or a part of this question. So tracheobronchial tree, if that is the question, how will you start the answer? Okay.
Starts
So,
from the lower border of cricoid cartilage.
tracheobronchial tree is a branching tree of airways which is composed of. Now, based on this first sentence I have given here, can you break down the components of the tracheobronchial tree?
Conducting airway and the
Conducting
respiratory.
zone and respiratory.
See, the name is given here, tracheobronchial tree. So you are starting with conducting airway, but this is an anatomy
Right
question.
main
Trachea
bronchus.
0, sir.
Right. Right main bronchi, left main bronchi.
So the first part is the trachea.
What is the trachea?
Bronchial tree. Second part is the bronchi. Third part is the bronchioles. Okay. So this is how you divide the tracheobronchial tree: the trachea, the bronchi, and the bronchioles. Okay. Now the tracheobronchial tree has branching structures, approximately 23 branches or generations, extending from the trachea, which is called generation 0, to the last order of terminal bronchioles, which is called the generation 23. Okay. So who classified these 23 generations?
Weeble, sir.
Weeble, W-E-I-B-E-L, Weeble's classification or generations of the tracheobronchial tree. Okay. Now, what are the characteristics of trachea? First, we will see the anatomy of the trachea. If the question is tracheobronchial tree, first you have to write about the trachea. What are the characteristics of the trachea, which you come across every day when you try to do an intubation, give general anesthesia to the patient? What is the normal adult trachea level? What is the structure?
From lower border of cricoid cartilage.
Lower border of cricoid cartilage to, that is up to the cricoid cartilage, it is larynx. So below the larynx.
Continues as larynx.
Below the
so up to what level is the trachea?
angle, sir. Up to sternal angle.
T4
T4.
sternal angle.
Until the bifurcation, until it bifurcates into the right and left main bronchus, it is the trachea. Okay. So the trachea descends from the larynx into the lung. It extends from cricoid cartilage level to the carina, which is at the level of sternal angle, where the trachea bifurcates into right and left main bronchus. And the trachea normally in adult is about 12 centimeters. What is the diameter of the trachea in an adult?
3 to 4 centimeters.
3 to 4 centimeters. That means 30 to 40 millimeters. Is that right? The length is 12 centimeters in a normal adult, whereas the diameter is only 24 to 26 millimeters. That is 2.4 to 2.6 centimeters. Okay. Whereas, what is the size of the tube that we use for a normal adult male?
8 to 8.5 mm.
8 to 8.5 or 9 at the most. Okay, very rarely you use 9, but normally 8 and 8.5 millimeters internal diameter. So if you don't use a cup, what will happen?
There will be leak
around the
leak. That is why we use a cuffed endotracheal tube to seal that gap between the normal tracheal internal diameter and the diameter of your endotracheal tube. Okay, that is the purpose of using the cuff. Okay? So the normal trachea is almost 3 times the size of the internal diameter of the endotracheal trachea you use. So in adult it is about 24 to 26. In female it is slightly lesser. That is why you use 7 or 7.5. And at the level of sternal angle, the trachea bifurcates into right and left main bronchi. And the trachea, what sort of cartilage it is made up of? It's a hyaline
C-shaped,
cartilage.
hyaline.
And it is C-shaped. What do you mean by it is C-shaped?
Posteriorly, it is.
The
It has
hyaline
muscle.
cartilage is not there at the back. So it is not the complete ring. It is only a semicircular ring, and the hyaline portion is in the front. Okay. Why posteriorly it is not complete? The
Because
hyaline
it can
cartilage
compress
is
the
covering only
esophagus.
anterior and lateral walls. What is the structure behind the trachea?
Esophagus.
Esophagus can get
So if
compressed.
the hyaline ring is complete and it is a hard structure, won't you have problem every time you swallow? Isn't it? So that
Yes.
is the reason why the tracheal rings are only C-shaped or partially compressed. So the posterior wall of the trachea is formed by a muscle called trachealis smooth muscle. How many of you have heard about this trachealis smooth muscle?
Yes, sir.
Yes, sir.
So
Yes, sir.
how many cartilages are there?
16 to
Normal
20.
16 to 20. Yes, already I've shown the answer. With cartilage rings connected by annular ligament, and the tracheal cartilages rings are responsible for keeping the tracheal lumen open in spite of the changes in the intrathoracic pressure that occur during respiration. Okay, and so coming to the trachealis muscle, what is its function? It connects the ends of the C-shaped tracheal cartilages. You see in this picture, this blue thing is the cartilage.
Cartilage.
Okay? And this dark brown structure which connects the tips of the cartilage is the trachealis muscle. Okay. So imagine when this muscle contracts, what will happen? It will bring the two ends of the
Constricts the
cartilage
airway.
closer and narrow the lumen. Okay. So it is in contact with the anterior esophagus. So this is the esophagus, which is the trachealis muscle is in contact with the anterior portion of the esophagus and functions to constrict the airway by pulling the cartilages together. So by when it contracts, it reduces the diameter. By decreasing the diameter of the airway, it allows for increased expiratory force during coughing and thus allows greater velocity to be achieved for the particle to be expelled. And this action is helpful, especially when eating food which requires expansion of the esophagus. Okay. So when you swallow and the food goes through the esophagus, this trachealis muscle constricts and reduces the diameter, thereby expanding the diameter of the esophagus. Okay. And histologically, this is a pseudostratified columnar epithelium, and there are seromucous glands and cartilages are there. Okay. Now, after the trachea, we have to see the anatomy of the bronchi. We have a lot of applications of this anatomy to us. So, how will you describe the anatomy of the bronchi? How many bronchi are there? Major bronchi.
Two major bronchi.
Two major
Two
bronchi,
right and left major bronchi. Very good. What is the length of right main bronchus and what is the length of left main bronchus?
2.5 centimeter.
Right.
75 degree.
Right is 2.5, left is
5
almost double. Okay. So at the level of P5, the trachea divides into the right and left main bronchus. So this is the thoracic vertebra P5 level. It divides into, and externally the landmark is sternal angle for that. So the right main bronchus is about 2.5 centimeters. Left is almost double the size, 5 centimeters. And the primary bronchi then branch into secondary bronchi, that is each lobe. How many lobes are there in the right lung and how many lobes are there in the left lung?
3 lobes on the right and the
Three
2
lobes
lobes
on
on the
right.
left.
2 lobes on the left. Very good. So each right main bronchus should divide into 3 lobar bronchi, upper lobe, middle lobe, and lower lobe bronchi. That is called the secondary bronchus. And similarly, on the left side, it will go into upper and lower lobe. And there is a lingular lobe. Some people call it that as the equivalent to the third lobe of the right lung. So each secondary lobe then go into tertiary bronchi or segmental bronchi. This portion is only called the bronchopulmonary segment. Okay, when you go to the tertiary level, if the question is worded, describe the anatomy of bronchopulmonary segment, it is enough if you write about these divisions. Don't have to write about the trachea, you don't have to write about the divisions of the bronchus and all that. So you must watch the question carefully. If they ask you anatomy of the tracheobronchial tree, you have to start from trachea, go to the division of the bronchi, go to the bronchopulmonary segments and complete the answer. If the question is only describe the anatomy of the bronchopulmonary segments, you can straight away go start writing about the tertiary or segmental bronchi and how it supplies the bronchopulmonary segments. So segmental bronchi undergo further branching to become what is called the bronchioles. Okay, so this is the picture which will tell you. This is the larynx from cricoid cartilage. This is thyroid. This is cricoid. From the cricoid up to this, about 16 to 20 hyaline cartilaginous, which are C-shaped, form the trachea. Okay, so this is the length of the trachea from the cricoid to the division into right and left main bronchus at C5 level. And of course, the posterior part is the trachealis muscle, which is responsible what we have seen. Once it divides into the right and left, you can see the right is very short because the upper lobe branch takes off at a very early level, so it is only 2.5 centimeters. Whereas in the left, the upper and the lower lobe, they take off at a lower level, so it is much more longer, 5 centimeters in length. And this is very important when we talk about the one lung intubation or endobronchial intubation with a W-lung tube. This becomes very, very important knowledge because when you play, normally we prefer to use the left side because we have a longer distance, so we can place the tube comfortably. Whereas if you don't place the tube correctly, you will be occluding the origin of the upper lobe bronchus on the right side, and that will cause a collapse of the upper lobe and atelectasis will happen. So describe the anatomy of the bronchioles. Now we are going down to the lower portion. They differ histologically from the bronchi as there are no C-shaped cartilages. Okay, so the cartilages are lacking in bronchioles. They are mostly made up of smooth muscles. And bronchioles initially divide into many generations, which become 3 components. One is conducting bronchiole, the second is terminal bronchiole, and the last is the respiratory bronchiole. So this terminal bronchiole, some people call it as also a transitional zone or transitional bronchioles, where they partly take part in respiratory gas exchange and partly act as a conducting zone. Okay, so this is how the bronchioles are divided, and they are lined by simple cuboidal ciliated epithelium. There is no cartilage or submucosal glands at this level, and they are surrounded by elastic fibers and smooth muscle. Then there is a separate cell called club cell, the major cell type in the epithelium of the bronchioles. What is the role of this club cell? They are protein secreting non-ciliated cells which show short microvilli that produce anti-inflammatory and immunomodulatory proteins, and also cytochrome P450 enzyme, which play a role in detoxification. So it is at the bronchiole level, the specialized cells called the club cells, which are doing the function of anti-inflammatory and immunomodulatory proteins, and also some enzymatic activity, which we saw in the last class as we discussed this in the last class under what heading? non-respiratory functions of the lung. That was the last discussion we had. Okay, so this
Yes,
anti-inflammatory and immunological function is the non-respiratory. That is no gas exchange, oxygen being taken in and carbon dioxide being on. That is the respiratory function. So this is one of the non-respiratory functions which is done by the club cells in the bronchioles. Now this picture, what does it show?
Bronchopulmonary.
This is what is the bronchopulmonary segment. Excellent. So if the question is asked on bronchopulmonary segment, you have to draw only this picture. Describe this. So this is the bronchi, which is about 2.5 centimeters, right main bronchus, left main bronchus 5 centimeters. From there it gives the upper lobe, and then each upper lobe bronchus divides into the various segments of the lobe, and you have 3 segments in the upper lobe, then you have 2 segments in the middle lobe of the right lung, and there are 5 segments in the lower lobe. Similarly, you have the same thing in the this thing also, and it's not moving. Something came. So a mnemonic to remember these segments. Sometimes, how do you remember the various segmental bronchi? A palm, MALP. So the mnemonic to remember that A is anterior, P is posterior, and apical. So APA stands for the upper lobe, and lateral and medial for bronchi for the middle lobe, and anterior, middle, anterolateral, anterior basal, medial basal, lateral basal, and posterior basal. Okay? So these are all the various segments. So 1 plus 4, 5 plus 1, 6 plus 4, 10. So a palm, yeah, another way of writing palm is MALP, MALP. A palm MALP is a mnemonic for bronchopulmonary segments on the right, and a PASI, a MALP. This is what you remember for the left-sided bronchopulmonary segments. So again, the same apical, posterior, and anterior will be there. Superior, instead of lateral and medial in the middle lobe of the lung, the lingula has got superior and inferior, and the lower lobe bronchi segments are the same. So if you remember this mnemonic, you can name all the segments equally. And what is the importance of knowing about the segments? Why do we have to know about this anatomy of the bronchopulmonary segments? So which segments of the lung are likely to be contaminated during aspiration in various postures of a patient, and why?
In upright position, posterobasal.
So we can lie supine, we can lie prone, we can lie lateral, we can sit up. So the 4 positions are there, isn't it?
Yes.
These are the 4 postures we can adopt. So if you lie in the supine, which portion of the bronchopulmonary segment is likely to get the aspirated material going in?
Apical segment.
Apical segment of lower lobes. Over the apical segment of lower lobes. Okay. So this is, you can see the picture here, apical segment of both lower lobes. So if you are lying supine like this, whatever aspirated material can easily go into the apical lobes. Okay. So that is the lobe which you have to suspect, especially patients who are in ICU, who have a chance of aspiration. If you are, that is why we have to keep changing the posture of the patient all the time to prevent this sort of aspirated material getting accumulated there. So apical segments of the lower lobes are the likely segments which will be contaminated. And apical branch project posteriorly from the lower lobe. As you can see, they are going posteriorly from the lower lobe. That is the reason. If the patient is sitting up,
Postrobasals.
Postrobasal.
Posterior
Gotcha.
basal and lateral basal. Okay. So this is the lateral basal bronchus and this is the posterior basal bronchus. So they are going right down in continuation with the main bronchus. Okay. So these are the two things which will be aspirating. So in the sitting position, lateral and posterior basal segments, because they project downwards. Okay. That is the reason why they can get contaminated. The third position, if the patient is in lateral position, just look at these pictures and see whether which one will be affected.
Anterior basal.
Mediobasal and apical.
Upper lobe bronchus on dependent side. See, because if you lie down on the left side, when it comes down, this is the first branch. Upper lobe, it can go to apical or posterior or anterior, any part of this is the first opening, isn't it? So when the fluid comes down here, this will go here. If you are on the right side, the upper lobe, this is the first opening. So patient will aspirate into the any part of the upper lobe bronchus on the dependent side, because they project laterally. Okay. Then prone position. If the patient is in prone position, which lobe will get affected?
Lower lobe.
Middle lobe on the right or lingular on the left. Okay, so if the patient is in prone position, you can see this is the middle lobe, this is the lateral medial, and this is the prone. So if the patient is going to be, imagine the whole thing is tilted backwards. So what will happen? This will become the posterior part. Okay, so the middle lobe of the lingula or the middle lobe on the right or the lingular on the left will be the area where it will be affected, because they projected downward and forward. Okay, so you have to imagine this whole picture with the patient lying in the prone position, then the middle lobe. So supine position, apical segment of lower lobe, or remember at least lower lobe. In the sitting position, basal lobe. In the lateral position, upper lobe, and in the prone position, middle lobe. So all these four lobes can be affected. That is the importance of one importance of this applied anatomy. Now coming to the entire applied anatomy of the tracheobronchial tree, these are all the points. Coming to the trachea, knowledge of the length of the diameter is essential to select appropriate ET tube, especially for spontaneously breathing patients and in pediatric age group. What will happen if you select a smaller tube than what is required for an adult and allow them to breathe?
Resistance.
Resistance will increase, and what is the complication that will happen? Negative pressure pulmonary edema will happen. Okay, especially if you use a very small size tube compared to the tracheal diameter, patient will not only have difficulty, work of breathing will increase because of the resistance, they will also have negative pressure pulmonary edema. And the bifurcation of trachea is equal up to 3 years of age. So if you are not careful, can become endobronchial intubation both on the right or on the left, depending upon the direction you use. So children, this is a common pediatric question asked in the examination in the Viva. Up to what age the bifurcation is equal? It is up to 3 years. After that only, it becomes like an adult at 25 degrees for right side and 45 degrees for the left side. Okay, the angulation varies. So more chances of right endobronchial intubation compared to the left side. Okay, so that is happening only after the age of 3 years. So up to 3 years, you have to be very watchful. And tracheostomy, where do you perform tracheostomy? Which is the safe level to perform tracheostomy? It is about the third or fourth tracheal ring level by open or percutaneous method. Okay. Then tracheomalacia is a serious complication in the post-op period after removal of long-standing huge thyroid gland. So free of bronchoscopy will help to identify this condition, and you must get a consent for tracheostomy if you anticipate or suspect tracheomalacia to happen. Okay. Now, congenital anomalies like tracheoesophageal fistula require a good anatomy knowledge of the trachea for proper tube placement. and also to give proper anesthesia during intraoperative period to close the fistula and prevent gastric distension. Now, the length of the left main bronchus helps for a better placement of double lumen endobronchial tubes. This I have already told you, as the right tube may cause obstruction to the upper lobe division. Now, coming to the applied anatomy of bronchioles. They lack cartilage and are more prone for constriction by allergens or pollutants, leading to bronchospasm or bronchoconstriction, because they are made of mostly elastic and smooth muscle fibers. That is the histology. So they don't have lack cartilage. So they go in for easy constriction, or they can be dilated with the drugs to facilitate breathing. Now, coming to the pulmonary segments, we saw which are all the segments where aspiration can happen, and this is also very important to find out for proper physiotherapy, how to place the patient to remove the accumulated secretions in the various lobes of the lung. And also it is important for need for post-op ventilatory support after a lung resection. So one of the important pre-operative estimation you have to do is how many lobes you can safely remove or how many segments can be removed, and whether patient will require post-operative ventilatory support or not is determined by the calculation of the remaining lung segments after you detect the segments which you are going to resect. So these are the various pictures where you can use the postures for removal of the various secretions. This is also sometimes asked in the examination. So this picture is available in many textbooks. You can read that. And finally, infantile respiratory distress syndrome is one of the conditions which occurs in the premature birth due to insufficient production of pulmonary surfactant or abnormal lung development in the babies. So it usually surfactant production begins at 20 weeks of gestation. So from the 20th week of intrauterine life only, the surfactant production goes on, and will be maximum up to 36 weeks. So if the baby is beyond 36 weeks, then there is no fear of this particular complication. So before 36 weeks, you have to make sure that the surfactant production is normal. So as far as possible, try to postpone the delivery up to 36 weeks for this particular reason. And the inefficient ventilation and gas exchange result in hypoxia and hypercarbia. And you have to do a prompt recognition and treatment to prevent that. And we normally give dexamethasone. If you are going to deliver the baby around 36 weeks, always give dexamethasone to the mother, which will improve the maturity of the lung, also improve the surfactant production and prevent this complication. And similarly, there is a congenital condition called alpha-1 antitrypsin deficiency, which is an autosomal recessive genetic condition leading to, which can affect the lungs as well as the liver. And this is a lack of this enzyme, the serum alpha-1 antitrypsin level, lead to unchecked inflammatory response in the lungs and the eventual degradation of lung tissue, leading to progressive COPD and pan-acinar emphysema. So this enzyme is very important for removing or breaking down the secretions. So if that is not functioning properly, or if it is not available in adequate quantity, that will cause accumulation of all these fluids and produce an inflammatory response leading to destruction of the lung. Now, this is another common question. What is hypoxic pulmonary vasoconstriction? This is another short note question repeatedly asked in the examination.
It is a protective mechanism to prevent VQ mismatching, sir.
Excellent. So this is a protective mechanism. It's a reflex constriction of vascular smooth muscles in the pulmonary circulation in response to low regional partial pressure of oxygen. That is alveolar oxygen level when it decreases. It is not the blood oxygen level, but the alveolar oxygen level. If it is going to be less, then the blood supply to that particular alveoli is cut off or removed by vasoconstriction. So this is a protective mechanism to prevent V2 mismatch and to maintain the V2. What is the physiology in HPV? How does the vessels know that the alveoli are not having adequate oxygen and I should close? What is the mechanism? How do they do that? So this is a systemic circulation dilates normally in presence of hypoxia, whereas in pulmonary circulation, they go in for vasoconstriction. How they do that is a protective physiological reflex to divert the blood from the hypoxic areas to better ventilation and oxygenation. So the nature of pulmonary circulation, low resistance, low pressure means this is caused by localized high resistance to blood flow and promotes diversion of flow to areas of lower resistance. So as you all know, the pulmonary circulation compared to the systemic circulation has got only 1/10 of the pressure in the systemic circulation. So it is a low pressure circulation. So regionally it can constrict and divert the blood to the other areas. Now, what is the mechanism leading to this vasoconstriction? It is the two factors. One is the alveolar oxygen level and the mixed venous oxygen level. These are the two factors which determine that. And the site of action is the pulmonary arterial smooth muscle cells. So that is the arteries only can constrict. So that is the smooth muscle which constricts. And the mechanism involves three components. One is biological oxygen sensing. Second is the smooth muscle contraction. Third is the modulation of these two responses. So once the oxygen level in the alveoli is sensed, immediately if it is low, the smooth muscle go into constriction. And once the level improves, automatically the constriction will get relieved. That is the modulation that is done. Now, how they happen, there are different theories how they sense this and what happens to the smooth muscles. One is the direct modulation of potassium channels. So there are potassium channels present in the vascular endothelium, which direct modulation happen. Changes in the cytoplasmic redoxation state, mitochondrial reactive oxygen species production, cellular energy state or concentration of high energy compounds, alteration of membrane bound protein function, activation of transcription enzymes which via hypoxia induced factor, alteration of cyclooxygenase or lipoxygenase system. And these are all the various theories. That means nobody is quite sure of what exactly is happening. So there are about 7 theories proposed. And hypoxic pulmonary vasoconstriction mechanism is susceptible to modulation. So it can be either inhibited or enhanced. So it can be altered by certain things. So direct modulation can occur through changes in the intracellular pH or temperature. And humoral modulation via angiotensin 2 in the human beings can happen. And the predominant modulation is localized mediators like the pulmonary endothelial cells in the presence of hypoxia. And mediators produced by pulmonary endothelial cells also cause this mechanism. And nitric oxide is the most important transmitter, although not fully understood, is continuously produced by pulmonary endothelial cells and maintains a constant state of pulmonary dilatation. That is done by reducing the intracellular calcium, which is responsible for the smooth muscle contraction. So when calcium is not available, smooth muscle relax. The hypoxia induces basal nitric oxide production and thus hypoxic vasoconstriction is enhanced. So this is nitric oxide production will be reduced immediately once there is no oxygen available. So the vasodilatation of the capillaries will be abolished and vasoconstriction will ensue. So these are the other mediators like prostacyclin and endothelin 1. They also have some role, but the major thing is the nitric oxide. Now, what are the clinical implications of this hypoxic pulmonary vasoconstriction? Why we should know about that? For instance, under general anesthesia, there is no known to lead to atelectasis because of the diaphragmatic elevation and altered ventilation perfusion matching. So using unnecessary high fractional inspired oxygen concentration during general anesthesia may not only contribute to absorption at less places, but in ventilated areas, this will inhibit the hypoxic pulmonary vasoconstriction. So it will lead to VQ mismatching. So you should not use unnecessary high fractional inspiration, especially nowadays with the use of medical air, oxygen and air combination. People tend to use very high percentage of oxygen compared to the 33% when we are using during nitrous oxide. Nowadays, people simply keep 1 liter of oxygen and 1 liter of nitrous, air, so that produces a high concentration. And during one lung ventilation, it is the hypoxic vasoconstrictor reflex which mainly prevents the VQ mismatch. So that is the main thing that happens because of that protective mechanism. And arterial oxygen saturation less than 90% with an FiO2 of 100% is commonly accepted as the level at which some intervention is required during one lung ventilation. So if you are giving 100% oxygen, and if the saturation remains less than 90%, that means hypoxic pulmonary vasoconstriction is not working properly, and we have to go in for some corrective mechanisms. And what happens during epidural, high epidural anesthesia? What does it do to HPV? Reports of decrease in oxygen tension related to epidural anesthesia during one lung ventilation are more likely due to decrease in cardiac output and decrease in mixed venous oxygen saturation compared to and not due to an effect on hypoxic pulmonary vasoconstriction. Now in lung diseases, how does it help? Patients with COPD tend to have less of a response than normal patients. So they are very dependent on HPV to maintain adequate VQ mismatching. Patients with liver failure often have a relative hypoxemia, which is called the hepatopulmonary syndrome. Okay, this is also mainly because the hypoxic pulmonary vasoconstriction is not functioning properly. And this is characterized by preserved pulmonary blood flow to atelectatic lung, causing diminished HPV response. That is what is happening in hepatopulmonary. And exact etiology of this response is because of increased pulmonary endothelial production of nitric oxide. And carbon dioxide and pH, how do they affect that? Both respiratory and metabolic acidosis causes pulmonary vasoconstriction, and the response resulting from alteration of extracellular hydrogen ion concentration. So if you have a metabolic acidosis or respiratory acidosis, they will automatically try to improve this vasoconstriction to abolish this VQ mismatch. And hypercapnia and acidosis have inconsistent effect on HPV. Attenuation of HPV by alkalosis is more consistent finding than effect on acidosis. So if you hyperventilate and wash out the carbon dioxide, the HPV response is more pronounced. What are the drugs which can affect the HPV? The phosphodiesterase 5 inhibitor group, that is sildenafil, is an established oral therapy for pulmonary hypertension. It inhibits hypoxic pulmonary vasoconstriction by impairing cyclic GMP breakdown, potentiating nitrous oxide and dilatation of pulmonary. So pulmonary hypertension is treated by relaxation of the pulmonary arterial smooth muscles. Inhaled nitric oxide is a potent pulmonary vasodilator with a short half-life, hoping to rapid inactivation by hemoglobin. So nitric oxide is inactivated by hemoglobin. And this inhaled increase in nitric oxide level is indicated in children or babies born with hypoplasia of the lung like diaphragmatic hernia, where to salvage or before the surgery you can keep the pulmonary circulation pressures low, because the patient will invariably have pulmonary hypertension in those conditions. So nitric oxide selectively reduces pulmonary vascular resistance and improves cardiac output in pulmonary arterial hypertension. It is used in pediatric intensive care as a therapeutic action for respiratory failure with severe pulmonary hypertension in young babies, especially in babies with diaphragmatic hernia. Prostacyclin analogs or potent systemic pulmonary vasodilators also have antiplatelet and antiproliferative effects. And pharmacological agents like epoprostenol treprostinil, and iloprost. They are all the prostacyclin analogs which you can use. And delivery options can be by IV infusions or inhalation by nebulizer. And catecholamine with beta receptor effects like epinephrine, dopamine, and dobutamine, they inhibit the hypoxic pulmonary vasoconstrictor at standard doses. So in patients who have respiratory problem, use of this for supporting the circulation may worsen the hypoxic VQ mismatching because they interfere with this hypoxic vasoconstriction. And vasopressors with a predominant alpha-1 action like norepinephrine or phenylephrine, they enhance or increase the activity of this vasoconstriction. And arginine vasopressin causes systemic vasoconstriction via vasopressin V1 receptor, and it has pulmonary vasodilator property at low doses through nitric oxide dependent mechanism. And endothelin receptor antagonists like bosentan, sitastatin, which are all used in treatment of pulmonary hypertension, they also have competitive antagonism against EP receptors. And acetazolamide is a carbonic anhydrase inhibitor that is commonly used to for altitude acclimatization. People who want to go for high altitude, they are given usually this drug as a pre-treatment for 3 days to prevent not only the HPV problem but also cerebral edema, which can happen at high altitude. They attenuate HPV response at high doses. And AC inhibitors, AC enzyme inhibitors, they also reduce the HPV response. The hypoxic pulmonary helps to match the regional perfusion to ventilation, that is the protective mechanism. And physiological factors which include or influence HPV include pH, PCO, temperature, age, and ion status, which we have already seen. And increases the pulmonary vascular resistance or pulmonary artery pressure, which can precipitate right heart failure. So if the hypoxic pulmonary vasoconstriction is very severe, causing pulmonary vascular resistance, it can precipitate right heart failure. Inhaled anesthetic agents inhibit the hypoxic pulmonary vasoconstriction in dose-dependent fashion. So whenever you use a inhalation agent like isoflurane, they all inhibit the H2O, but at clinically relevant doses, their effect is negligible, so you don't have to worry. But in lab studies, as the dose increases, they inhibit the effect. And managing acute severe pulmonary hypertension needs careful consideration to ventilation, fluid management, inotropes, and vasopressors. So this picture will show you how the hypoxic pulmonary vasoconstriction occurs. This is the pulmonary vein. This is a normal alveoli with a normal ventilation. So this is the venous blood that is coming here. So oxygen is taken up, it becomes arterial blood. Whereas here, the venous blood goes to an alveoli which is not well ventilated. So what happens? It goes into vasoconstriction. So the amount of unoxygenated or deoxygenated blood going and mixing with the normal pulmonary oxygenated blood is quantum is reduced. So this is the airway. This is the picture which you can easily draw in the exam to explain how the whole mechanism happens. So this is the picture that you have to remember. Now lastly, you have sometimes they ask you about oxygen flux. What is the meaning of the word flux? Flux means a continuous moving or passing by. So something that is continuously moving on or going through a particular area, that is called the flux. Okay. So what is oxygen flux? That means oxygen is going in a continuous fashion from the heart to the periphery and coming back to the heart. Okay. So the total amount of oxygen transported by blood per minute, which is it's called the oxygen flux, which is oxygen content of the arterial blood, which is equal to the blood volume is 5,000 ml, of which we take 20% oxygen, that is on the atmospheric air. So we get about 1000 ml of oxygen per minute. So the amount of oxygen that we get every respiration is about 1000 ml of oxygen. So the delivery of oxygen to the tissues can be calculated by multiplying the arterial oxygen content and the cardiac output. So the rate of oxygen consumption at rest is about 25%. So even though we have 1000 ml, only 250 ml is utilized. The rest of the 750 ml is brought back, leaving the venous blood 75% saturated with the content of 150 ml. Is happening in this picture. If you see, so arterial oxygen 200 ml is given. The oxygen extraction by the tissues is about 250 ml. So the venous blood going back is about 150. That is arterial 200 to 150 per ml. So alveolar minute volume is 5 liters. So calculating that, you get about the venous blood itself should have about 75% of oxygen. If it is reduced more than that, what does it mean?
The demand is high.
Extraction is more. So the demand is met by extracting more blood from the arterial tree and the venous blood sometimes. So oxygen extraction ratio is a very, very important tool to find out whether the tissues are getting adequate oxygen or not. Okay? So this is about the oxygen plus. This is not important. So that completes all the important points that we have to discuss on respiratory physiology, anatomy, and its applied implications for us as anesthesiologists. Okay. Any questions or any doubts?
Any questions from students?
No, sir.
All clear. All are had a good sleep.
So where exactly you think this hypoxic pulmonary vasoconstriction will be very, very significantly used in anesthesia, during anesthesia?
But the answer is question. He is also eligible to ask you questions. Which particular condition, hypoxic pulmonary vasoconstriction, has a very important.
COPD patients. We should avoid 100% saturation COPD patients to preserve this HPV.
HPV is a protective mechanism. That's what we have seen, isn't it?
Yes, sir.
The question is, where does it become?
So use of volatile anesthetics will
Clinical anesthesia, we are more worried about double human tube usage, one lung ventilation. So that is where we have to, because we purposely avoid ventilating one lung. So that lung becomes totally unventilated, no oxygen going there. So unless the entire lung vasculature becomes vasoconstricted, the blood will be still going as a venous blood and coming back, and that is the main reason how it decreases the oxygen saturation. Okay, so the VQ mismatch occurring in one lung ventilation. So the examiners usually ask you how you avoid this hypoxemia happening in one lung ventilation. That is a common theory question as well as your practical examination. If they show you a double human tube and ask you what are all the methods by which you can avoid hypoxia happening because of deliberate one lung ventilation using a double human tube, you'll have to say first you have to give 100% oxygen, then you have to give CPAP to the non-ventilated lung and feed to the ventilated lung. All those steps are there in the examination. All the books will give you about that. And finally, if nothing works out, you have to go for double lung ventilation. Or you can ask the surgeon to open the chest quickly and clamp that pulmonary vessel, which is not constricting, to avoid the mismatch. So that is one of the interference method of avoiding the hypoxia. Okay, so this is the common question they ask you. How because it is a HPV which is playing a major role in preventing hypoxemia to the patient in one lung ventilation. Okay, so that is the answer that got I think Dr. Thomas will ask you.
Yes.
Am I
Thank you,
right,
sir.
Thomas?
Thank you. Any question from students?
Okay, so that we finish our discussion on respiratory physiology anatomy. The next class we will try to discuss about the basics of cardiovascular system, which we have to know as anesthetists. Okay, so next class will be on basics of CVS, okay? Both anatomy and physiology and pharmacology of cardiovascular system. Okay, so try to read up all those basic things. We will try to discuss that in next class. Shall
Yes,
we
sir.
close?
Thank you very much, sir. Yeah.
Thank
Yes,
you.
sir. Thank you. Thank you very much, students. We'll assemble again in the next class. Thank you so
Thank you.
much. Happy Puja holidays
Thank you, sir.
for all of you.
Thank you, sir.
Thank you, sir. Thank you, sir. Happy.
Thank you, sir.
Happy Navratri for all of you. Thank you.
Thank you.
Thank you, sir.